What I'm going to try to show you here is a study on global phase 2 that was just finished of a new approach for BAFF inhibition and the subcutaneous administration of the BAFF inhibitor. Okay, what is actually the compound that we're talking about? Blisibimod is a peptide body composed of two identical polypeptides, and there's 4 BAFF binding peptides. In blue, you can see the place where we can actually bind the BAFF for inhibition. There's a high affinity for human BAFF, binds soluble and membrane, and has a long half-life, 8 to 12 days. The protocol that was designed was a protocol that's seen here in this slide with 547 patients. And it's a dose-ranging study, so there are 3 groups with placebo and 3 groups with the active drug. And then after a period, you can see they all went into open-label extension. And the metrics that were involved here, one is the FDA-recommended SRI, the Systemic Lupus Responder, plus the changes in BILAG and the PGA. Let's see what kind of results we had initially with this study. As you can see here, these dose-ranging studies did not show significant changes between placebo and the different doses. But however, you can see there is a definite trend that the 200 milligrams every week patients apparently seem to have a different trend for response with the SRI. And if you look here on the right of your slides, you can see here clearly on this graphic that you probably can pick up a significant response against placebo when you pull placebo against the pull active drug. When we go to the secondary efficacy results and we look into more severe stringent patients, we do find the differences that are quite interesting and significant. When you look at 7-point changes or 8-point changes, we can see on the Selena-SLEDAI groups that there is a difference between the placebo group and the patients receiving Blisibimod. When we also looked at flares and background of steroid dose, on the left you can see here the time that was not significant between placebo and patients receiving the 200 milligrams q-week dose, but there is a trend for more delayed on the appearance of a new flare. And when we look at the steroid dose that patients were taking, actually this particular protocol, you were allowed to decrease steroid, even discontinue if the doctor felt that this was the case. And you can hear quite a difference between the placebo group and the Blisibimod group on the mean average dose of steroids they were taking. This protocol was not allowed that you include patients with severe renal disease. But there were some patients that actually did have proteinuria when they entered the study. So this group here of 54 patients, when you compare the patients taking 200 milligrams weekly against the pool Blisibimod and the placebo group, one can see on the green there was a significant reduction in proteinuria on this particular subgroup of patients that were in the study. On the right side of the slide, when you look at biomarkers, you can see that what you could expect, that there's increases in C3, C4, and decreases in the titer of anti-DNA and the reduction in the total number of B cells. What about adverse events? Basically, adverse events were not different in neither one of the groups, placebo or patient receiving the active drug. I will call your attention here for the last part of the slide, severe injection site reaction. Probably this audience here is filled with doctors that have experience with anti-TNF blockers with subcutaneous injections, and some of you do know that some of these patients do develop severe site reactions, which was not the case with this anti-BAFF subcutaneous medication. So what can we conclude from this phase 2 study? There was actually the information that the most effective dose was 200 milligrams q weekly. There was improvement in secondary points, Selena-SLEDAI, and patients reducing steroid dosage. There was decreasing proteinuria in that particular subgroup I just mentioned to you, improvements in significant biomarkers, and there is a trend that the patient takes less steroid and the delay on the appearance of a new flare. The new phase 3 study now going to the recommendations that most of you people heard yesterday and this morning, we should go more for severe disease lupus patients to find out whether a particular drug is effective or not. Thank you very much.
We have time for questions from the presentation.
I can start with a question here. Morton?
Yeah.
Okay. I saw that there was an increase in the efficacy in the higher dose, in 200 milligram dose.
There was a trend for that.
A trend for that, and no trend for increase in side effects. Would you consider trying a higher dose than that?
Well, the study did not think, the study was actually 2 different doses, and the dose that was fixed to be tested was the 200 milligrams. This is actually going to be being debatable with the sponsor whether they want to try the higher dose or not. But certainly they could think of it because there was no adverse effects at all with the 200 milligrams.
Thomas Dörner, Germany. Morton, you have very substantial effects on the anti-DNA and complement levels. If you take them out in the SRI 7 and 8, what is the difference between placebo and the 200 mg group?
Let me see if I got your question correct, Thomas. If you take, because certainly I cannot see you, but I can recognize the voice. What is actually the question?
The question is, if you take from the SRI 7 and 8, the components anti-DNA and complement out, what is the difference between placebo and the 200 mg group?
I can't answer that right now, but I'm sure the database will have this information. We can probably forward to you later on, but I don't have this information right now.
Okay.
One more question, middle right.
Is there any information about the relative affinity and immunogenicity of this compound compared to monoclonal antibody?
I don't think we have this information right now, whether this is the immunogenicity. Certainly this could be a problem, but apparently it's not from the clinical observations that we have so far. But it certainly has to be looked at eventually when this product will come up into the market. But bear in mind, the major sponsor of this meeting here has an intravenous anti-BAF. We are trying to show you here initially the possibility that we may have in the future a subcutaneous anti-BAF to be given to our patients.
Thank you very much, Dr. Scheinberg.
Thank you.